Right. Without further ado, I'm very pleased today to welcome Dr. Terry Quinn. Terry is a reader at the University of Glasgow and an honorary consultant in stroke medicine. He's got a very broad research portfolio and is published widely in notable journals such as the NEJM and JAMA and the BMJ. He's also been on various editorial boards, including being the coordinating editor of the Cochrane Dementia Group, and he's deputy editor for Age and Aging. I believe he's also the NRS Scotland lead for aging research as well. And within the University of Glasgow, Terry is vice chair of ethics, and he coordinates clinical academic training. But perhaps most importantly, he's a trustee of SHARP as well. So we are very privileged to have Terry speak to us. I can think of no better person to talk to us about what are the hot topics in stroke in 2023. So Terry, over to you. I believe you can share screen.
Yeah,
thanks.
Thank you very much for that introduction. So let me share, and you can tell me if this is working. How's that? Or is that better?
That's better. Yeah.
That's better. Yeah.
Great. Thanks.
Okay. So thank you for that very kind introduction. I am Terry Quinn from Glasgow, and I've been asked to give you a bit of an overview of recent research around stroke. And I thought I'd just share with you my personal opinions on what I think is interesting, or to use the parlance of the kids, what's hot in stroke in 2023. So my details are down in the corner here, including my Twitter handle. If anything I say is interesting, or if you want to get in touch with me, you can get in touch with me through my email or through Twitter. So it's always good practice to begin these talks with any relevant conflicts of interest. I'm chair trial steering committees and data safety monitoring committees for stroke trials, but we won't be talking about any of those trials in this talk. I've received some investigator-initiated funding from BMS and Pfizer, but again, we won't be talking about that here. I will be talking about some of my research, and that's research that was funded by CSO and Stroke Association. But I guess the main thing that I have to disclose is just a note of thanks. When I was putting together slides on what's hot in stroke, I thought, I'm going to ask the people that are bringing the heat. So I spoke to friends and colleagues, including Professor Jessie Dawson from Glasgow, Dr. Alan Cameron from Glasgow, and Dr. Beth Davis from Brighton, who shared with me some of their work, and I'm going to share that with you today. So, as a SHARP trustee, I've been involved in the conversations where we've been thinking about these webinars, and you know, there's a bit of pressure because there were webinars last year that were really high quality, and when I was given my remit for this talk, I was told I had to talk about the latest developments in stroke. I had to keep it clinical. I had to be mindful that the audience is going to be multidisciplinary, so I had to have content that would be suitable for primary and secondary care and all the disciplines within those areas. But most of all, I had to not be rubbish, because all of the previous webinars had been of very high quality. So hopefully I'll be able to meet all of those criteria. No promises on the last one, and I'm afraid no refunds. So as I was thinking about how I would structure this talk, in my head, I had a list of 10 things that I thought were important and worth sharing with you. And just betraying my age a little bit, when I thought of a list of 10, I started to think of Top of the Pops. And for those of you who are too young or too cool to know what Top of the Pops is, it was a TV programme that used to present the best-selling pop singles of the time, and it would present them as a top 10. And that's the format that we're going to take today. And in my top 10 of what's hot in stroke, I'm going to cover all aspects of the stroke pathway, from prevention through acute stroke, through secondary prevention, right through to the longer term aspects of stroke. Important caveat, this is my own personal reflections on what I think is hot in stroke care. Other people may think that other things are important, and that's one of the nice things about stroke. There's so much happening in it at the moment. I could actually have had a top 20 or a top 30 list of things that were hot, but for this evening, we're going to stick to 10. So coming in at number 10, we're going to talk about stroke prevention. So we know a lot about stroke prevention. The Interstroke study was a massive international case control study. Part of it was coordinated by Peter Langhorne, who came from Glasgow. And Interstroke told us that blood pressure, obesity, inactivity, this is walking the dog East End of Glasgow style, high cholesterol and smoking accounted for about 85% of all ischemic stroke. And then if you add in some other risk factors, if you add in alcohol excess, diabetes, structural heart disease, a bit of genetics and socioeconomic deprivation, you can explain 90% of all ischemic stroke. I think this is important because I often find that people feel they have an understanding of coronary heart disease and they understand the risk factors, but they feel that stroke is somehow different and it's more complex. And you have to be thinking about esoteric things like vasculitis or patent foramen ovale, and you really don't. The vascular risk factors for coronary heart disease and the vascular risk factors for ischemic stroke are actually very similar. Of course, there's still 10% of stroke that isn't explained by these factors, and that's what keeps my job interesting. And what's very important about this is that almost all of these risk factors are modifiable. Some are easier to modify than others. Some of them can be modified with drugs. Some of them need behavioural interventions. Socioeconomic deprivation needs a political intervention, but it is still potentially modifiable. And if we can get this right, we can make a huge difference. This is really quite an old slide now, but I think it makes a very important point. The Express trial was based in the stroke clinics of Oxford, and they moved from what at the time was a very good service to really a Rolls-Royce service. They moved from a stroke clinic that was on a few days a week to a 7-day-a-week service, immediate access and immediate prescriptions of medications. People came to the clinic and they were given their first tablets actually within the clinic. And what they showed with the Express paradigm is, if you see people with TIA quickly and if you get medication started quickly, you can make a huge difference to outcomes. We have here on this graph the number of recurrent strokes in orange in the first wave, their standard clinic, and then the number of recurrent strokes in the second wave when they had that Rolls-Royce service, and it decreased substantially. So getting prevention right makes a huge difference. But we can't be complacent. So this is a meta-analysis looking at the risk of stroke following TIA across different time periods. So in the black dots here, we have the risk of stroke following TIA from the 90s. And you can see the risk was really pretty substantial and it increased over time. And here we have 7 days, and you can see that between 5 and 6% of people with TIA were having a recurrent stroke. Now, thankfully, that's decreased. Here you can see the decrease. But what's a worry to me is things haven't continued to decrease. So this group here, the most contemporary estimates really aren't much different to the estimates from about 20 years ago. There's a worry there, and there's still scope for us to try and prevent recurrent stroke in people that have TIA. So that moves us on to my number 9 and my top 10 of hot stroke topics, which is atrial fibrillation. Now, strokeologists have always been interested in atrial fibrillation because if we think about the causes of ischemic stroke, they can be classified in these 5 broad categories. And cardioembolic stroke is almost all atrial fibrillation, give or take a couple of rarer conditions. But what we're realizing more and more is that a lot of those strokes that we used to call cryptogenic, unexplained in their etiology, were also caused by AF, but they were caused by paroxysmal AF, and we just hadn't caught the AF at the time that we looked for it. So actually, a huge proportion of stroke is probably caused by AF. And you maybe don't need me to tell you how risky AF is, but let's just have some figures here. AF gives you a 5-fold increased risk of stroke. And once you're aged over 55, you have a 1 in 3 risk of having an AF-related stroke. Huge. And you can see the number of people living with AF is due to increase over time. What's become more apparent recently is the more that you look for AF following stroke, the more likely you are to find it. And here we have a meta-analysis from colleagues in Greece that looked at PCM, which is prolonged cardiac monitoring to look for atrial fibrillation following a stroke, versus standard care. And this meta-analysis, standard care could be different things, but standard care would usually be a 24-hour cardiac monitor. And you can see that with prolonged cardiac monitoring, you pick up lots more atrial fibrillation, and you start lots more people on anticoagulation. However, what this meta-analysis didn't show was that that was making a difference to stroke recurrence. You could argue there's a suggestion of a difference here. The absolute numbers are different. In the prolonged cardiac monitoring group, around 4% of people had a stroke recurrence, and that was higher than 5% in the non-prolonged monitoring group, but that didn't reach a statistical significance. Maybe it's a question of numbers. But nonetheless, prolonged cardiac monitoring is here, and it's something that we're using more and more in stroke care. And you've got lots of different flavours of monitors. And this is something you're going to come across in primary or secondary care, all of these different options for looking for atrial fibrillation. We have patch devices with devices that can be worn up to 1 month now. We have R tests, we have implantable loop recorders, and we have single lead devices, including apps that can be used with a smartphone. We're still trying to understand exactly what the information from all of this monitoring means. There is no doubt that this sort of monitoring is different to standard care many years ago, which would have been a 12-lead ECG. And as we get more information, we have more questions emerge. On prolonged monitoring, how much atrial fibrillation is enough to be a threshold for initiating anticoagulation? And the truth is we don't know the answer to that. And that's why, where I work in the Royal Infirmary, we've set up a stroke cardiology MDT, where we meet once a month and we discuss these difficult stroke cardiology interface cases. And that MDT approach is something that's now being rolled out across different bits of the UK. So let's move along the stroke journey now, and let's think about hyperacute therapies. The proven hyperacute therapies are limited in number, but they are highly effective. So a few years ago, we had 4 things in the toolbox for hyperacute stroke. For ischemic stroke, we had aspirin. For all strokes, we had admission to a stroke unit. For certain strokes, we had intravenous thrombolysis. And for strokes that caused brain swelling, we had decompressive neurosurgery, a decompressive hemicraniectomy. And in this illustration here, I've just put the numbers needed to treat. So for aspirin, you need to give 100 people with ischemic stroke aspirin to prevent a recurrent stroke or death. For admission to a stroke unit, for every 20 people admitted to a dedicated stroke unit, 1 less person will die or have a recurrent stroke. For alteplase, intravenous thrombolysis, you're looking at a number needed to treat of 10 to prevent serious disability. And for hemicraniectomy, the number needed to treat is actually only 2. But we have to put those data in the context of the number of people that are eligible. So all ischemic strokes are eligible for aspirin, and ischemic strokes tend to be about 80% of all stroke presentations, with the other 20% being bleeds. Every single type of stroke, whether it's ischemic, hemorrhagic, and regardless of the severity, benefits from admission to a stroke unit. So the percentage eligible for stroke unit is 100%. At the moment, about 10 to 15% of UK stroke admissions are eligible for thrombolysis. The number of people that require and are eligible for hemicraniectomy is 1% or less. Although it's a very effective therapy, the number of people that need it is actually quite small. So that was the state of the play recently. And the big change in hyperacute stroke therapy is thrombectomy. Mechanical retrieval of clots is commonplace in cardiology, but for a long time, the trials of thrombectomy in stroke suggested that it was harmful. And I think a lot of that was just to do with the technology that was available at the time. And you can see a timeline here of stroke thrombectomy devices, which in the 1990s were this sort of toothpick with a bit of a lasso on the end, and they've evolved over time to these very sophisticated stent retriever devices. And using those new generation devices, it's now very clear that mechanical thrombectomy for people presenting with a stroke caused by a large vessel thrombus is effective. Here we've got a meta-analysis of all of the different trials looking at mechanical thrombectomy versus best medical care, and almost all of them were effective. And in the meta-analysis, you can see you have a number needed to treat of 3 for any improvement and a number needed to treat of 5 to prevent disability. So we can add that to our toolbox. What proportion of people are eligible for thrombectomy? Well, that's something that we're still finding out. And that's still evolving because advanced imaging may make the proportion of people eligible for thrombectomy even larger than the estimate that I've put there of 15%. So if thrombectomy is so good, surely we're doing that in the UK. Well, actually we're not. And we're certainly not doing it in Scotland. In this little graph, I've shown the proportional uptake of thrombectomy in various countries. And at the moment, the UK has the same number of thrombectomies as, say, Russia. And that's something that's got to change. And that is something that's changing at the moment. However, in the middle of last year, the Scottish government said that they were going to disinvest in thrombectomy. They had to make cost savings, and money that had been earmarked for rolling out thrombectomy and developing a national thrombectomy service was going to be cut. And I didn't think that was okay. And actually, all of the stroke clinicians in Scotland didn't think that was okay. So we got together, supported by the Stroke Association, supported by Chest, Heart and Stroke Scotland, and we campaigned. I found myself on TV, which was slightly uncomfortable, but I did my bit, and the campaign was successful. Thrombectomy funding and the rollout of thrombectomy has been reinstated in the mini budget at the end of last year. So in a time when we can often feel quite jaundiced about the politicians controlling healthcare, actually, if you can make a compelling argument, you can often find that you're listened to. So let's move to number 7 in my top 10, and we're going to talk about our old friend, antiplatelets. So antiplatelets in acute stroke used to be pretty easy. In the first few days, you would give aspirin because aspirin was the only thing that had been studied in acute stroke. And here we have data from the International Stroke Trial showing that aspirin has benefits. It's not a panacea, but giving aspirin early seemed to prevent stroke, seemed to prevent other vascular events, and had an effect on mortality. In the longer term, and again, these are really historical data now from the Capri study, clopidogrel seemed to be efficacious or slightly better than aspirin for longer term prevention of vascular events. So that's what we used to do in stroke care. When people came in acutely, they would have aspirin, and then at some point they would transition to clopidogrel in the longer time. And life was easy. But of course, evidence continues to evolve and things have become a little bit more complicated now. What we've realised is that for minor stroke and TIA, the risk of recurrent stroke is incredibly high, much higher than we first appreciated. And it's been shown that dual antiplatelet therapy, combining aspirin and clopidogrel for a short period, can substantially reduce that risk. So now for this high-risk group, we use dual antiplatelet therapy, usually for around 21 days. In UK practice, it's aspirin and clopidogrel that we use, but this recent study from the New England suggests that maybe we should be thinking about ticagrelor. Ticagrelor, of course, a drug that will be familiar to people working in cardiology. In this study, they took people with high-risk TIA or minor stroke, and they were randomized to a combination of ticagrelor plus aspirin or placebo plus aspirin. And they looked at rates of disabling stroke. And you can see that in the ticagrelor group, there was less stroke overall and less disabling stroke. So the jury is out as to what flavour of dual antiplatelet you should use. But what I think is clear is that in these high-risk TIA and minor stroke populations, we need to get in early and we need to get in with strong, potent antiplatelets for a short period. So let's continue moving along the stroke pathway. And we're now going to have a think about rehabilitation. Traditionally, rehabilitation has been considered as not having as strong an evidence base as some of the acute therapies that we use in stroke. But that's not to say that there isn't evidence for rehabilitation interventions. There is. In this little graphic, I've outlined some of the different approaches to rehabilitation, including using robots, using virtual reality, using mirror therapy, using functional electrical stimulation. For most of these, there is some evidence that the rehabilitation can improve, for example, strength or balance, aspects of neurological impairment. But what most rehabilitation trials haven't shown is that they can make a difference to broader function, therefore make a difference to activities of daily living, therefore make a difference to overall quality of life. And these are the metrics that are needed for health economic analysis. And these are the metrics that are really needed if you want your rehabilitation intervention to make its way into guideline recommendations. But we had a good news story in summer of 2021. For the first time, the FDA approved a rehabilitation device. And the device was this, it was vagal nerve stimulation therapy. So in this little graphic here, it shows you the vagal nerve stimulator. So you have a stimulator, a battery-operated stimulator that's implanted under the skin. Electrodes wrap round the vagus nerve. And the idea is that by stimulating the vagus nerve, you create a transient state that enhances neuroplasticity. So if you can combine stimulation of the vagus nerve with a rehabilitation task, you can improve the recovery that you'd otherwise have from that rehabilitation task. And so that was the basis for the VNS therapy trial. So in the VNS therapy trial, people with arm problems chronically following stroke were randomized to what was really quite intense rehabilitation, or that same rehabilitation, but coupled with vagus nerve stimulation at the time of the rehabilitation. And the hypothesis was that by stimulating the vagus nerve, people would have a greater benefit from the rehabilitation. And that is exactly what they found. So here we have results of the trial comparing a sham VNS to proper VNS stimulation with intensive rehabilitation. And you can see here that differences became obvious post-therapy and they were maintained. If you do the statistics, you're looking at a number needed to treat of 3 to prevent disability using VNS compared to control. So, are we going to see VNS in the UK NHS? Well, I think that's still up for debate because it is an expensive therapy. But what I think is important about this study is it's proven that rehabilitation interventions can work. And that's reignited interest in this whole area. And I think we're going to see lots of new rehabilitation interventions coming along in the wake of the VNS success. So now we're moving to something that I think is interesting. Hopefully I'll convince you is interesting as well. And that's frailty in stroke. So frailty is one of those words that we use a lot, but we perhaps don't always know what the precise definition of frailty is in a research context. So frailty is a reduced ability to recover from a stressor, such as, for example, a stroke. And I can illustrate that with a cartoon here. In green, we have a robust older adult, happily living their life. They have some illness, that could be a stroke, for example, which causes a decline in function, but they're able to recover. And they get back to where they were before, and they continue living their life with no functional dependency. For the older adult living with frailty, it's a different pattern. You can see they're already on a trajectory of functional decline. They have the same illness as this person, but their response to that illness is exaggerated. They become more functionally impaired than you would have imagined for that level of stressor. They have a prolonged period of recovery. They don't recover to the level of function that they had before, and their trajectory of functional decline may change as well. So that might all seem quite abstract. Let's apply it to some stroke scenarios. So here we have a robust older adult. They have a TIA that causes a transient change in function, but they make a full recovery. Then perhaps they have a minor stroke that causes a larger change in their function. They may cross a threshold where they have a period of dependency and they require other people for help with activities of daily living. But with time and rehabilitation, they get back to where they were before. And then for the major stroke, much more dependency, much more time requiring help from others. But with acute therapies and with rehabilitation over time, and perhaps in iterations, the person improves, although never gets back to where they were before. Contrast that to the person living with frailty. You can see even something that we might consider benign, like a TIA, can cause dependency. A minor stroke can cause a long period of dependency, and even with rehabilitation, the person never gets back to anywhere like the function they had before. And despite all of our evidence-based treatments, major strokes and frailty are often terminal. I want to share with you the theory of frailty now. And the main theory of frailty that we accept is a theory of cumulative deficits. That's a theory that says the more things that go wrong over your life, the more likely it is that you're going to be vulnerable to the next insult that comes along. So the cumulative deficit model of frailty is serious. And it's so serious, I'm going to illustrate it using some of my kids' toys. So here we have a Jenga tower, and that represents a robust older adult. And here we have an external insult, which is a stroke. Boom. You can see that when the older adult has a stroke, they wobble a little bit, but they weather that insult. Let's now introduce a lifetime of factors that make that person less robust. So let's introduce anemia, heart failure, a history of falls, labile blood pressure, depression. All of these things over the life course make that person a little bit less robust. It's like removing blocks from the Jenga tower. Now, when the stroke comes along, the system collapses, and that's the theory of frailty. And if over the life course we have more insults, perhaps we add in mild cognitive impairment and visual impairment and atrial fibrillation, the tower becomes more and more unstable. And you can see here, even with no external insult, that already looks slightly precarious. And something relatively benign like a TIA can again lead to a complete system failure. So that is frailty. Why am I so interested in frailty? Well, we've been looking at frailty in the group here in Glasgow. We pulled together all of the papers describing frailty in acute stroke. And there's a few things just to draw your attention to. The first is, this is pretty new. Most of these papers are from the last couple of years, and a lot of them are from the UK. But whichever way you look at it, there seems to be a lot of frailty in people that are presenting to stroke units. And if we put that together in a meta-analysis, 1 in 4 people presenting to hospital with stroke already has frailty. And I think that's got huge implications. It's got huge implications for how we plan our services. And it's also got implications for acute treatment decisions. So I worked with the team in Belfast in Northern Ireland. They've been measuring frailty on people presenting for thrombectomy for many years. And so we had a look at their data. What we found, perhaps unsurprisingly, is that frailty was associated with death and it was associated with disability. But what we perhaps didn't expect was the size of that association. Frailty was by far and away the biggest predictor of a poor outcome in terms of death or in terms of disability. And now here we've got some data from one of my collaborators, Nick Evans, who works in Cambridge. He looked at frailty in people receiving thrombolysis. Again, unsurprisingly, the people living with frailty didn't do so well following their stroke, but he actually found that frailty was a treatment effect modifier. And the more frail someone was, the more likely they were to not benefit or even be harmed by acute therapies like thrombolysis. So, hopefully I've convinced you that frailty is important. Those of you working in acute care in Scotland may have seen this. This is the Healthcare Improvement Scotland Frailty Tool, something that I helped develop with HIS And this is supposed to be employed on everyone that is admitted to hospital, aged over 65, for unscheduled care. It's been designed to be simple to use, and it's just another way of identifying those people who are living with frailty and perhaps making you think a little bit about whether you need to adapt what you're going to do because of that inherent frailty. So let's move from, I guess, physical frailty to cognitive frailty. And let's talk about vascular cognitive impairment, another area that I'm particularly interested in. So I'm interested in it, but let's face it, everyone's interested in dementia. Dementia is the thing that's on everyone's mind. Nobody wants to get dementia, and the newspapers almost every week have some new thing that either causes dementia or seems to cure dementia. We have been involved in a few cohort studies looking at how many people following a stroke have vascular cognitive impairment and dementia, as have many other people. So last year, we pooled all of those studies together and we performed a meta-analysis asking the question, how many people living with stroke actually have dementia? And the top line answer is that 1 in 5 stroke survivors will have dementia. Now, the devil's in the detail, and it depends a little bit on your definition of dementia, whether you include people that had dementia before their stroke, because that puts the figures up a bit. If you exclude them and you're only thinking about people that have a dementia following stroke, it goes down to about 16 or 17% of stroke survivors, but that's still a huge number. And if we start to break that down a little bit, we can see the proportion with dementia changes over time. The reason it seems to tail off is a survival effect. People living with dementia tend not to survive over many, many years. And we can also see that factors like whether it's your first stroke or a recurrent stroke are incredibly important. Recurrent stroke seems to be very, very strongly associated with having dementia following your stroke. Now, another thing that begins with D that's bad for your cognitive health in stroke is delirium. And again, delirium is something that we've been looking at here in Glasgow. So we had a look at all of the published data on delirium and acute stroke, and we found that, again, 1 in 4 people with acute stroke will either present with delirium or develop delirium during their stay. But actually, that may be an underestimate, because a lot of the studies included in this meta-analysis actually excluded the people who were at highest risk of developing delirium. So they excluded people who had aphasia. They excluded people who had a history of alcohol abuse. They excluded people who had dementia. So when we ran a truly consecutive study in the Royal Infirmary assessing for delirium on everyone that came in, regardless of these criteria, we actually found that the rates of delirium were closer to 1 in 3. So that's big news. I would just remind anyone that has even a passing interest in delirium that the 15th of March this year is World Delirium Awareness Day. Now, for World Delirium Day, internationally, we're trying to do a snapshot audit, looking at the prevalence of delirium in hospitals and coordinating that for Scotland. And if that's something you'd like to take part in, then please do drop me an email, because we're still looking for more sites to help with that. Plug over. The talk is what's hot in stroke, and I gave you some epidemiology there that maybe doesn't seem that hot to you, but there are actually big changes happening in vascular cognitive impairment. Having been an area where we had no treatments at all, I think we're going to see that change, and I think we're going to see that change over the next 1 or 2 years. Studies looking at cardiovascular drugs are now starting to look to see whether they also have an effect on dementia. So, for example, the Evoke Plus study program is looking at novel diabetic agents, but seeing if they have an effect on dementia. There's also a lot of interest in repurposing existing cardiovascular drugs to see if they can help with vascular dementia. The LACI-2 trial was led from Edinburgh, and it looked at isosorbide mononitrate and cilostazol, both vasodilators, to see if they could help prevent vascular dementia following stroke. Now, the results were presented as a late-breaking session at a stroke conference at the end of last year, and it does seem that they work. And that's a game changer, because we've had nothing before that seemed to prevent vascular cognitive impairment. And if you've read the newspapers, you can't help but have heard about these monoclonal antibodies to amyloid, lecanemab being the one that's most recently been assessed by the FDA. Lecanemab is good and bad news for people working in stroke. If it prevents dementia, of course, that's good news, but the side effects of these monoclonal antibodies are that they cause stroke and they cause intracerebral hemorrhage. So you pay your money, you take your choices. But whatever your interpretation of those trials, I think we're going to see some big news in the field of vascular cognitive impairment treatment in the next short while. So let's move to number 3 on my list, which is priority setting. What I made very clear at the start is that this top 10 that I'm presenting are things that are of interest to me. But actually, if we want to be systematic, we should ask people living with stroke what's important to them. And that's something that the James Lind Alliance does. And I worked with James Lind Alliance a few years ago, and we asked stroke survivors, their caregivers, clinicians, academics, people from the third sector, to list what they felt were the most important unanswered research questions in stroke. And we received thousands of replies, and we were able to distill that into a top 10. And here is the top 10. And you can see that actually a lot of them are around cognition issues, mood issues, emotional issues. That was a priority setting exercise that was really restricted to Scotland. But last year it was run again, supported by NIHR and the Stroke Association. And they ran actually 2 priority setting exercises. One asking what are the research priorities in acute care and pre-hospital settings, and then another one looking at longer term. And I've just got here what the priorities were that came from that exercise. Some of the things that I've been talking about tonight, you can see that frailty is there, and also things that I've maybe not spoken about, but that are clearly important, like intracerebral hemorrhage and early recognition of stroke. Here's a list for longer term problems following stroke. And again, you can see psychological problems and cognitive problems top the list. These are the things that stroke survivors worry about. And then there's some other things there, and perhaps some things that you maybe haven't thought of before, like the effect of stroke on caregivers, or how to organise community services. So those James Lind priority setting exercises came from Scotland and then from the UK, but actually there have been priority setting exercises from all around the world. So as a project last year, we pulled all of them together and we created a synthesis looking to see what were the global stroke research priorities. And they're here on this slide if you're interested, or you can have a look at the paper. But what became very apparent from that exercise is if you're going to do a priority setting exercise, the answers you get depend on who you ask. So some of the priority setting exercises only asked caregivers. And of course, what came out of that was that caregiving was the top priority. Priority setting exercises that only asked, in inverted commas, professionals tended to focus on biomedical things. And I think that the most important ones are the ones like we did in the UK, where you actually ask people living with stroke what's important to them. So we're almost done. Number 2 in my list is guidelines. I think guidelines are very important for shaping stroke care. Apologies, this is live TV and someone is phoning me. I'm just going to turn that off. I have the privilege to be the chair of the European Stroke Organisation guideline group. And we've been publishing a variety of guidelines and continue to. We published more than 10 guidelines last year. And we try and publish guidance on areas where we feel guidance is needed. So around things like, what do you do if you do a scan and you find small vessel disease that you weren't expecting to find? What do you do if you have someone that has cognitive problems following stroke? And just since I have speaker's privilege, I'll just plug another CPD exercise if you haven't had enough from tonight. We run webinars when we release our guidelines, and we have got 2 guidelines that we are releasing in February. One looking at the condition of moya moya, and another one that's maybe more relevant, looking at the new thrombolytic agent called tenecteplase. So if you want to find out the latest European guidance on those things, there's a webinar. It's on Thursday, the 2nd of February, and the URL is there. But again, if you want more details on that, you can email me. But it's not because of the European guidelines that I've put guidelines on the list. guidelines are on the list because there are new UK guidelines that are currently out for consultation and they'll be published later this year. So these are the guidelines from the Royal College of Physicians. And I've just selected some of the recommendations they make. I think they're correct, but I also think they're going to be quite challenging for stroke services in the UK to deliver. So I'll just talk through some of them, and you can think about, your own local stroke service and how much work they'll have to do to try and deliver on these things. So for imaging, we say that every stroke service should have access to advanced imaging immediately. And for TIAs, they should have access to immediate MRI. For TIA, they say that there should be a 7-day-a-week service to allow people to be seen within 24 hours of their TIA. For people admitted with stroke, they say if they have mild to moderate disability, they should be offered early supported discharge, and that service should begin within 24 hours of them being discharged home. For rehabilitation services, they say that rehabilitation services should have access to tele-rehabilitation that allows remote rehab. And again, just think what that actually means. Until recently, I was still using Windows 7 on my NHS computer. So the thought of tele-rehab really seems light years away. And then just to show that the things that I'm interested in aren't just my own personal bugbears, you can see that actually there's a whole section around delirium in the latest national clinical guideline. I'm pushing for there to be a section on frailty in the next iteration. So we've made our way through the top 10 and we're now at the number 1 hottest thing in stroke. And the hottest thing in stroke here is the planet. I don't think you can work in healthcare and not be cognizant of the effect of climate change. This isn't unique to stroke, but I think everyone working in healthcare has to be aware of the effect of climate change. It's quite cold today, but cast your mind back to the summer. We had the hottest summer on record, and that's something that's been recurring every few years. And that climate change presents a real triple challenge to healthcare. We have to build systems that are resilient to climate change, and we have to try and deal with the burden that comes with climate-related disease. And we also have to recognise that healthcare itself contributes to climate change, and we have to try and create net zero health systems. Not easy, but there are resources there, and there are resources specific to stroke. So within the British and Irish Association of Stroke Physicians, we've set up a green stroke group, and I would encourage people that are interested in stroke and green issues to join that group. Even within SHARP, we've been doing some work around air pollution. You're maybe not aware of just how much the NHS contributes to climate change, but it's substantial. And the breakdown is here in this pie chart. And I think when you're faced with this, it's easy to be nihilistic and to think that there's nothing you can do, but actually there are things you can do. So I want to end just on some practical steps that you could take to try and be the agent for change around the climate consequences of healthcare. I think we do need to hold management to account. We need to be asking hospital management, what is our hospital doing to try and have an impact on climate change? If you're involved in education or if you're involved in training, I think you need to start incorporating sustainability issues into that. You could support audits or QI looking at sustainability. And within British and Irish Association of Stroke Physicians, we actually have a sustainability audit competition. And I think what's most important is to join up with other like-minded people. And if you work in stroke, please do join the Green Stroke Network. So there you have it. That's my top 10, with everything from primary prevention through frailty right through to climate change. A completely personal, a completely subjective list, but hopefully there were some things in there that you found interesting, and hopefully you agree with me that all of those topics are important. We're going to open up for questions in a second, but if any of that was of interest to you, and if you want to get in touch with me, my email is here and my Twitter handle is here. And I'll just end the way all these webinars end, reminding you about SHARP. SHARP is free to join, and we're always trying to improve our membership. So if you're interested in heart and arterial disease, please do get in touch and think about joining us. And with that, I will stop sharing my slides. Hopefully, this one.
Fantastic. Thank you very much, Terry, for that excellent talk. Really wide-ranging, taking us right through from prevention to management and rehab, relevant issues, and ending at with climate change as well, which is very relevant, as you said. So thank you very much for that. It's very informative, certainly not rubbish. So thank you for your time and expertise. I'm just going to open up for questions. So if I can remind the audience, please raise your hand, turn your camera on if you wish, and ask your questions, or you can type in the questions in the chat box. There is a question already from Rebecca. I think it's Rebecca Wheater. And Rebecca asks, do you think artificial intelligence interpretation of CT and MRIs will be a game changer in stroke assessment and thus thrombolysis and other management around AI and interpretation of imaging?
Yeah, I mean, I think it's already changing stroke care pathways. So we are using Brainomics software, and in other parts of the UK, they're using other AI platforms, and they're only going to get better. However, I think you still need a clinician. The AI can help your decision making, but you still need that clinician to interpret all of the other things that the AI struggles with and to give that clinical nuance that the AI just can't do.
Yeah, perfect. Thank you, Terry. While I wait for any other questions from the audience, can I just ask you about the challenges of delivering a thrombectomy in a geographically very disparate country like Scotland so that we prevent a postcode lottery healthcare system? What are your thoughts on how the system should be set up?
Oh, it's a real challenge. It's a real challenge. And one of the reasons that there has been delays to thrombectomy is there was a concern that thrombectomy was a postcode lottery, as you say, and it was available if you lived in the right area. And if you happen to live somewhere else, you just didn't have access to it. So one of the nice things about working towards delivering thrombectomy is I really think it's brought the Scottish stroke community together. So we now have weekly webinar meetings where we talk about some of the practical issues around thrombolysis and thrombectomy. We try and educate each other and we try and work through these issues. I'm not sure we've got the answers yet, but the model looks like it will be 3 hub centres across Scotland, and then the country will be divided up with people travelling to their nearest hub centre.
Yeah, thank you. I think we've got Iris Grunwald here who had a CT scanner in her ambulance, I think when she was working down south, and she used to travel this, take this ambulance to the patient almost.
Yeah.
So another question from Rebecca Martin. You mentioned finding unexpected small vessel changes on scans in asymptomatic patients. How would you manage these patients? Can you advise? Yeah,
so I can refer you to our ESO guideline on that topic. And what we found in the guideline, this probably isn't a surprise, is there is a real lack of evidence. Treating blood pressure seems to be a useful thing to do. Statins, unclear. In the ESO guideline process, if there isn't clear randomized controlled trial evidence, we then go to an expert consensus. And within the group, there was a real debate about antiplatelets. If you find small vessel disease in someone with no history of stroke, should you give antiplatelet or should you not give antiplatelet? And there are arguments both ways. Finding small vessel disease is usually a marker of systemic vascular disease, but that small vessel disease, those are friable vessels that are more likely to bleed. And eventually, after lots and lots of debate, we decided that you shouldn't routinely give antiplatelet unless there's another indication from other cardiovascular disease.
Thanks, Terry. Can't see any hands raised. Feel free, people, to just type in questions or raise your hands. Another question, Terry, just really while we're waiting for other folk to raise their hands, is frailty is really not unique to older populations. Is there any evidence that younger frail patients have worse outcomes than older, fitter patients, or vice versa?
Yeah, it's a really good question, and it's one of the hot topics within frailty at the moment. So the tools we have for assessing frailty have really been validated for people aged over 65, or for some of them for people aged over 75. So you need to be careful about applying them in younger populations. During COVID, across the UK, the UK government said we should perform frailty screening on everyone using a thing called the clinical frailty scale. And there was a real backlash against that because people were worried that that might be used to deny younger people access to intensive care. So I think there's still a lot of work to be done in that area. But what I can say from clinical experience working in the East End of Glasgow is we see people in their 50s who are clearly frail and their outcomes are poor.
Yeah, thank you. David Simpson asked, will ticagrelor be advised to be used soon in any of the guidelines?
Yeah, so the RCP guideline that's out for consultation at the moment does mention ticagrelor. What we don't have is a head-to-head study of ticagrelor aspirin versus clopidogrel aspirin, because clopidogrel aspirin is really becoming standard of care for TIA and minor stroke. So I think that's unanswered. And I think the guideline will say you can use one or the other.
Great, thank you. We have Christian Dellis asking a question as well. Professor Dellis asked, hi Terry, it's impressive data on stroke management. When it comes to diagnosis of small strokes or TIAs, our pathways often involve a CTA or MRI, which can take several days to get given current pressures. This often leads to prolonged admissions. Is there anything that can speed up the diagnostic process for small strokes and TIAs?
Yeah, so in the guidelines, they're recommending MRI, which is the best modality for small stroke. CT actually isn't that useful. They're saying you need to get it within 24 hours, but here in the real world, we know that's difficult. What we've done in the Royal Infirmary and other hospitals in Scotland have done the same, as we have taken our MRI brain sequence and we've shortened it right down to a 5-minute sequence. And it only answers the question, is it acute stroke? But if that's the only question you want answered, then you can get that limited sequence, we call it a fast track MRI. And actually in our service, they're able to fit those MRI scans in while they're doing the safety checklist for people that are getting the full 30-minute full sequence MRI. So that's one practical solution that we've found to try and help with those patients. And there are always many of them where you're asking the question, is this a migraine? Is it a TIA?
Terry, is that fast track MRI sequence protocol available for other boards in Scotland? Do you know if that'd be very useful?
I'm sure. So it's diffusion weighted imaging and FLAIR, and it's literally a few minutes.
Great, thank you. Tanya asks, what support would you like to see from the primary care sector, both pre-stroke and post-stroke?
I would actually turn the question on its head. I think the more important question is what support do primary care need from us? Because I realise how much pressure primary care is under at the moment. And the last thing I want to do is start asking more of them, because I think they're really, things are stretched in primary care, and anything secondary care can do to help, please let us know. We had a project in the Royal Infirmary a few years ago where we had what we called a stroke phone, and at any time of day, people could phone and get advice from a research registrar that we had at the time. And it worked so well. The GPs loved it because they had immediate access to, a specialist in stroke. And actually, we loved it because we were able to really triage and streamline our referral service. Now, that was a research project. It didn't have funding to continue, but I think models like that work really well. Models that allow for just some direct communication between primary care and the stroke service.
Thanks, Terry. Tanya, or any of the primary care physicians, you want to come in terms of Terry's question back to you of what secondary care could do to help primary care? You're more than welcome to do so if you wish. I can't see any hands raised, Terry, and I think we've had a number of really useful questions, and thank you for your answers to them as well. Tanya is asking, is that phone line still open? I'm guessing no after that research project ended. Yeah, okay. So it just leaves me to thank you, Terry, for that fantastic tour de force of stroke, what's new in stroke. And thank everyone who attended the webinar. I hope you found it useful, and please consider joining SHARP if you haven't already, and look out for webinars coming up. I think the next one will be on managing peripheral vascular disease. We will highlight that through emails and the usual channels closer and nearer the time. Okay, thank you everyone for your time, and have a good evening. Bye now.
Thank you. Bye now.
Thanks,
Bye.
Terry.